So welcome everyone to our next session, looking at intervention, looking at the different models that we have across the province. And we are so pleased today to be joined by four different groups across the province who are going to share the models that they have around intervention within their communities. And as you will see, before I introduce everybody, that everyone does have a different kind of approach or intervention strategy or programs within the jurisdictions that they live in. And as you're quite familiar, that we don't have one sort of consistent model in every community. And one of the fortunate things that we wanted to host today here is to let people know what is available within your area. But if you don't live within the jurisdictions that our speakers live in, just thinking about as they talk, how their programs could be adapted or implemented within the areas that you live in. Because we can always learn and develop the programs, and we need to expand that because there are so many people, seniors living at risk in the communities. So how can we expand the programs to make this consistent so people don't get left, in a gap of services where they exist? Just trying to make this more equitable across the province is so important. And that's the work that we continue to do and advocate for, is to ensure that all communities have a contact agency that can do that response and intervention. So I think that's just important to point out. So we are going to give you today a sort of a snapshot of some of the best practice models that have proven to be successful. And I know, just speaking to our presenters, I know with Ottawa region has been in place for over 16 years. So we know that these are best practice models that have been in place for quite some time, that have proven to help older adults living at risk or experiencing abuse. So we're going to focus on four programs today that are specific to their regions that they reside in. So I would like to introduce our panel today. So our first panel representative is Samantha Kim. She is the Vulnerable Seniors Lead for CMHA and Waterloo, Wellington area. Kim, if you want just a little wave, that people can see your hand. Next, we have Joanne Riley, and she is the Senior Support Consultant with Home and Community Care Support Services. She's a part of the senior support team with the Waterloo, Wellington area, and works in collaboration with the Waterloo Regional Police when situations of abuse do arise as well. Next, we have Katherine Studiman, who is also, she's a registered social worker, psychotherapist, and she's involved in the mobile response program with Norfolk OPP. So she responds in the capacity around mental health and OPP, and she will talk a little bit about her role in terms of supporting seniors. And just before this discussion, we were just talking about some of the services that they have. So I think you're going to learn a lot from Katherine and the work that they do, from that connection, both with Joanne and Katherine, around working with policing partners. And lastly, we have Brad Spooner, who's a program manager for Nepean, Rideau, Osgoode Community Resource Center, and is the program manager for many, many years. He's will indicate that he's not responsible for the elder abuse response and referral service, but oversees that program, knows the ins and outs of that program, being the manager for so many years. So welcome everyone. Thank you for joining us today. I would like to begin the panel by just having everyone just take 2 to 3 minutes, just talking a little bit about what your program is. Just describe what the role is and what the main focus of your mandate is within your program. And I guess we'll just go in that order that I introduced you in. So Samantha, maybe you can just start just to give people a sense of what you do within your capacity and role with CMHA.
Yeah, definitely. So I'm the Vulnerable Seniors Lead. I oversee the Seniors at Risk program, which we have one clinician, but it is a team-based. We do fall under the seniors mental health team, but our service is quite broad. We support older adults who are vulnerable or living at risk, not just addressing the elder abuse. So we work from a person-centered, strengths-based, and client-directed approach to services, unless obviously there is a risk of harm to self or others, then we work towards safety of the person. Our ultimate goal is always to provide the direct service. We provide consultation, coaching, assessment, and intervention for older adults who are living at risk. We assist to mitigate the immediate risks. We try to, provide support, assistance with goal planning, assist with connecting to formal and informal supports. We have found that oftentimes our vulnerable seniors, they're not connected to any supports, whether it's formally or informal. They may not be aware of that, and we help with those connections to such as home and community care. We can do some system navigation because we know the senior system and the healthcare system is quite confusing and overwhelming for our older adults. We do short-term follow-up and monitoring, complete the risk assessments, and we always work collaboratively with our clients and family service providers to develop that care plan or safety planning. Our length of service is generally short-term, but it's case by case. And we know that some cases require longer term support and some are shorter term just to stabilize the situation. And we don't work in that crisis mode. We're Monday to Friday, unfortunately. And so we're not that crisis, but it does take us a few days to get through referrals and sort of build a picture of what's going on. So that's what we do.
Great, thank you. Next, we'll just go maybe to Katherine.
Okay, so I'm Katherine Studeman. I'm a social worker. I work in Norfolk County, just south of London. Simcoe is where our detachment is. Simcoe, not Simcoe County, but the town of Simcoe, very small rural area. So I work with I'm actually employed with community addiction and mental health services. They cover Studeman and Norfolk. But I am with the Mobile Crisis Rapid Response Team, MCERT, embedded within the Norfolk OPP detachment. So we work 7 days a week from 8 a.m. till 6 p.m. And there are 2 of us that rotate through on that continental rotation. I'm a registered social worker. My colleague is a registered nurse. We also have a part-time social worker that covers off our education vacation days, just so we try to eliminate the officers having to go without any sort of coverage when possible. So the way our role works is we are first response. So as I said, we're embedded right in the detachment. We're in the constable's room. We have a desk there. I wear a bulletproof vest. And we are partnered with an officer each day, and we attend calls for service in the community that are primarily mental health and addictions related. But being in a rural community, we just don't have the calls for service that maybe someone would in a city center. So we're not with a designated officer each day. We could be with any officer, and we go to all of their calls for service with them. That's how the program operates in our community. So my officer has, a motor vehicle collision, is going to a domestic, is going to a sudden death. I'm attending all of those calls with them. I may not really be involved in the call, but sometimes I'm there to, at the end of their investigation, to, connect people to services. We all know that if people are calling the police or they're involved with the police, they are probably not having a good day and are in some sort of a crisis situation. So primarily we're called to mental health and addictions calls, and we can travel throughout the community. Our officer takes us to those calls, and that's where we often get connected to a call for service with our older adults in our community. So sometimes it's a family member calling for a well-being check on someone. Because family members geographically, as we know, are living further away from their loved ones. So maybe they don't have the ability to check in on them. So they'll ask for us to go and do a well-being check. So that's in a nutshell what we do.
Great. Joanne? Oh, I can't hear you, Joanne.
Sorry, I had myself double muted just to make sure there's no background noise. Good morning, everyone. My role is actually very similar to Sam's, just that I actually work for home care and community support services. My role is the senior support consultant, and it's a partnership role with Waterloo Regional Police Service. So my office is actually at the police station. And so what we do is generally we are responsible for investigating and addressing cases of alleged or confirmed elder abuse. And we are also person-centered and strength-based. And so the work that we do is largely guided by the client's willingness and consent to participate with us. Katherine said it, like a lot of the times, if somebody's in crisis or they want help, a lot of the times they don't realize that with my role, there is a possibility of police involvement, and that really can impact the involvement in our service if an elderly person is dealing with, say, an adult, say, abuser or an adult child, where there's a control dynamic and there might be a fear of reprisal. So we're very aware of that. And so in combination with those concerns, we're also responsible, because I'm with home and community care, I'm also responsible for ensuring that the appropriate services, that the senior is connected with appropriate services. And so we want to make sure that all of their health care needs are addressed, but we also want to make sure that we're able to address the social needs as much as possible. And that really is where we step into partner with community service organizations like a Canadian Mental Health Association, like the behavioral response team, the hospitals within our region. So we have a lot of partnerships with different organizations to ensure that our older population is supported when when we're working with them, and also when there's a time that we decide that, okay, our SST or senior support role is no longer needed, but then they still need supports in the community as they learn to be more independent, depending on what their situation is.
Great. Thank you, Joanne. Brad? Oh, you have to mute.
Always the case. I'm always muted. Anyways, it's great to be here. Thanks for the invite. And so our particular program, we have a team of 2, if you include myself, a team of 3. But as Rianne pointed out, I just oversee the program. And a little bit of our geographic boundary in Ottawa is inclusive, and Ottawa is fairly vast city because it encompasses the urban, suburban, and the rural communities. And of course, the Elder Abuse Response and Referral Service is the only social service program in Ottawa that deals with issues related to elder abuse. And our program is specifically for victims of elder abuse and organizations that obviously support people who are potentially victims of abuse as well. And so in terms of, before I speak a little bit more about our process around intake, we have an intake worker that does intake 2 days a week, designated for 2 days a week. And we have a case manager who supports the intake process for 3 days a week. So it's not a full-time service. Now, that has fluctuated over the past 16 years since we've had this program. As we're able to secure private funding or funding from other sources, we're able to increase our capacity related to intake, case management, and of course, when we have funding support to do education and awareness, we're able to deliver more on that as well. So that's that's a little bit different model because it is specific to funding sources as well. In terms of our process around, when somebody calls, we support seniors 60 plus. And we also deal with a lot of service providers, families, friends, neighbors who are concerned and are calling on behalf of somebody. So it is really a collaborative process, we find, when we're dealing with incidents of elder abuse. And there's a couple ways you can access, or people can access, our services. We have a designated intake line that they can reach, or we also have a referral form online, which is primarily used by other service providers who want to provide us information that way on a particular client. And so that's, that's our process in terms of how we work with potential clients.
Great. Thank you all for that introduction, just an overview of your programs. And as just sort of taking some notes of similarities and some differences, I think there's, as many of you sort of talked about, that it's not crisis response, depending on what the circumstances is. I know in Katherine, working with your role with the police, it sometimes is crisis response, but then people may be on a list where you just kind of, or someone calls in terms of going out in terms of supporting individuals. Just maybe explore, I wonder if we could just in a general sense, just explore what is that relationship for each person's with your police services. Or I know, Joanne, you're in the office at the police services, and Katherine, you talk about wearing the vest. So I'm assuming sometimes you're in the office and sometimes you may be in all your role within that mandate, working with seniors. What's that relationship look like when you're working with police? So you have sort of that direct connection, and with Kim and Brad, it's kind of maybe informal. Maybe we could talk about the differences within that relationship, or if the relationships are similar. Maybe I'll start with Katherine and then maybe go to Kim.
Okay, so it's actually a really great partnership. And the longer I work with certain officers, we learn how to work well with each other. So first and foremost, it's always a police call. It's always a call for service with police. So depending on what the call is, like it could be a well-being check, it could be we may be getting called out for somebody that has been involved in a romance scam or some sort of financial scam. And so the officer will do their investigative piece, but then I'm there kind of in the background. I'm listening to questions. I'm listening to answers from the person. I'm kind of assessing for capacity or any sort of mild cognitive things that might be happening that might have played into this situation. I'm thinking about, I'm listening for, do they have resources? Do they have supports? And so while the officer's doing their investigation, I'm kind of like doing my own assessment in my head. And then when they're done, then I will step in and offer support. So let's say it's been a romance scam. We all know that there's a lot of shame and guilt that comes with that. So I will also speak to the person privately and just ask about suicide risk and if they're having thoughts of harming themselves. I ask if they want any support in talking to family members about this, because I know sometimes there's a fear base around that. So I have the ability, so I'm there in the crisis situation, but I also have the ability to follow up afterwards. And I'll just ask one of my officers, I'll just say, I need to go back out and see this person again. I want to make sure that they're okay. Or so I do some of that short-term follow-up, but I allow the officer to do their investigative piece first, and then I will do my assessment after. And as I mentioned earlier, sometimes there is a language barrier as well, but our police services have a telephone translator service available to them 24/7. And it's a number that they call, the officer provides their badge number, and then whatever language it is, they will come within minutes with a translator. And I've even taken an older person out of their home when they were very fearful of the people they were living with, but I couldn't understand what she was saying. And we actually took her out to the cruiser, and I sat in the cruiser with her. I put her in my spot in the front seat, kicked my partner out of the driver's seat, And I did the translating services, helped her with utilizing the phone and getting her the help that she needed, because she was actually being abused in her home by her caregivers. So yeah, it's a pretty cool response. The officers rely heavily on me, but I also rely heavily on them for safety and the piece that they're doing as well. So it's a pretty cool partnership.
And Katherine, just in terms of that relationship, do they go in plain clothes, or is it always a uniformed officer and a police car that you were just talking about?
Yeah, because we're always responding to all of the calls for service with the officers, they're in uniform. We don't have a designated mental health officer. We're not a secondary response. We're first response. So we never know what the situation is going to be when we get there. So it's all about safety. I mean, obviously, if it's a domestic or something big, I'm not going into the call. I'm not running in with police. I'll hang back in the cruiser. And then when it's safe to do so, I will enter into the home and possibly offer resources or connection to services or that type of thing. But no, we're always in uniform, partnered up together, and it is a first response approach.
Great. And Kim, what's your relationship with the Waterloo, Wellington? I know that you kind of cross jurisdictions in a few areas of policing services. So I'm not sure if you work with the multiple different police services. Maybe you can speak to that.
Yeah, definitely. So we do have a partnership with Guelph Police Services. They have a seniors at risk investigator, which is part of the domestic violence and intimate partner team. So our role does cover only Guelph Wellington. So they would be working with our seniors at risk clinician, kind of like Katherine, like they would be in their sort of secondary though, instead of primary. But yes, we have that. And then we work in the rural areas in Wellington County. We have our OPP partners where they have a seniors liaison and a mental health coordinator. So there's two different roles. So we do work with them. But within CMHA, we also have our impact team, which also, covers Waterloo, Wellington area. So they would also connect into Waterloo Region Police where Joanne is, and then they are covering Wellington County and the city of Guelph. So they are the first responders, going out if there's a mental health crisis. They cover all age spans, just like Katherine's team does. And then we will get the referrals from the impact team, or we get referrals from our seniors at risk investigators from the city of Guelph Police.
So would you do a similar role with Katherine, that you would accompany with a police officer to a senior's home, or you strictly after they have maybe done their investigation or their check on the older person?
So Katherine's role would probably be equivalent to our impact team going out with police. They would get called out. They wouldn't actually go in the cruiser. They would be called out if police arrive first, and then they feel like impact needs to be involved. They can call them out for a live call. With our seniors at risk investigators through the Guelph Police Services, they're often in plain clothes. They're secondary. Then our clinician can do joint visits with them. Sometimes it may not be helpful to have police back in, and so the police officer will go in first and try to connect and talk about, the seniors at risk program and how our role can connect with services, doing that assessment like Katherine's doing, looking at what the social concerns are in the home, and also assessing for, that healthcare need piece there.
Okay, great. And Brad, your relationship with the just in terms of Ottawa Police, I know that they have a seniors team there. You have to unmute, Brad.
Always do that. I start talking without unmuting. Our interactions with the police are not that extensive. I would call it on a needs basis. If through our intake process, it's determined that there's a criminal element and we need support from the police, we have in the past, and we will in the future, obviously, engage with them in a way that we see it necessary. In the past, we have done a few wellness checks with them, and obviously their process is their process, and we're there to support from a social, a social service perspective. And that's really our lens with our program, is the social service side. when there is a criminal element to it, we refer the individual over to the police or make that connection over to the police with them or for them.
Great. Joanne?
So my involvement with the police is, it depends on really the risk. And so sometimes I do go out, but just like CMHA, our service is not considered, at least with the senior support team, it's not considered a crisis service. And so I will go out with the police at times to client homes, sometimes in the hospital, and especially if it's confirmed that the client or the elderly person does not have care needs, then I'm going to see and assess if there are care needs that need to be further assessed by the team. And I'm also looking at like capacity, how they're answering their questions, to see if I need to now forward this client to the intake department with home and community care support services, to see if they need to be assessed by, say, an occupational therapist, or they need to be assessed by a care coordinator.
Great, thank you. I think it's important. I think the theme here is that there is a partnership element to all of your roles, and not only working with police, but other community partners in terms of responding and supporting older adults who are at risk or experiencing abuse. And I think we all learn, those who are joining us today, as well as yourselves, that we can't do this alone, that we do have to work collaboratively with our community partners, whether that's, police or other health and community services. One of the elements I was just wondering about, we were talking about everyone's role is different in terms of the funding and where you're situated. So I just wondering if you could speak to like the sustainability of your programs. I'm going to start with Brad, because you mentioned about trying to find money to keep the program going. And that's really, it's a challenge that you try to keep that program successful as it has been, but you spend so much time maybe trying to get the money to keep the program going, and how that might be different than from the programs where it's already integrated with the OPP. Do you find that for everybody, do you have to advocate for that funding or continuation of that program every year, or is there that increased need that we're seeing in the communities that's saying, yes, we need to have more funding and more allocation of resources to support the work that you're doing? Because many of you said you're only one person to do the whole area that you live in, and we know that the increase of calls has been escalated, especially since COVID. And how do we cope with that demand and then that lack of resourcing in terms of funding structure to hire more people to support? So maybe we'll start with Brad. Maybe if you could maybe comment on that.
Yeah, I think in terms of is more funding needed? Absolutely. I mean, we're able to offer 2 days a week of intake support and 3 days a week of case management. Now, the intake is sustainable because it's our organization's intake worker that does this intake. And the case management position 3 days a week is sustainable from the funder as sustainability is, right? That could be cut at any time. Who knows, right? But in terms of how we're going to do our education awareness and our outreach work, that needs to be an additional person. And we definitely notice a huge difference when we're able to do that outreach work. But that's all done by project funding. We have to seek funding to do that, whether it comes from a private funder or it comes from a government level funder. We have to go and look for that and apply for that, and for that to be approved. But Ottawa's pretty big. It's 1 million people, and it's diverse and it's vast and it's inclusive of rural, suburban, and urban, as I mentioned before. So, based on part-time work that we have right now, workers at this point, obviously we could be far more effective with more funding to sort of serve a geographic areas as large as Ottawa. And elder abuse is hidden behind social isolation and other factors that sometimes we, you know, if we were able to do more work with seniors who are isolated and have other vulnerabilities, I think we'd find that there would be an increase in elder abuse cases that come as a result of that. So outreach is critically important, but there's no funding for outreach, and there's not enough funding for the frontline work either.
Yeah, I think that's you hit a key thing on that. You bring up the education awareness, because we know that World Elder Abuse Awareness Day is coming up in June, and many of us are out there, informing people about the prevention tips and where to go for help. And then sometimes that's a catch-22, because you maybe spend that one time, but then your caseload increases significantly, and then be able to meet that demand. So we know that it's obviously a need. And if we're able to reach out to more and more people besides just one day, we could make a bigger impact in supporting older people if we had that resource piece. How does that work within home and community care, Joanne? I know, so we know that there's home and community cares across the province. But from my knowledge from working in this field for many years, you're the only one that I know that has a dedicated position in this factor. So how does that operate, or how's that functional, and how can we implement that across the province, or has there been talk about that?
I know that there's talk about it in general. However, for the actual agencies individually, I'm not as sure about that. And that is a conversation that I do have to have with my managers for them to take back to upper management, because it really does do a disservice to the rest of the population to only have this one position in this silo in this region, when we know, I know when I was listening to one of the earlier presentations, like the legal one, we talked about like the different demographic, right? We know there are a lot of demographics are changing within the Greater Toronto area and surrounding areas. And it's problematic when, number one, we have immigrant populations that are aging just as quickly as the populations that have already been here. And then we don't have the services that are available for them, not only in their language, but also we don't have the service available for them, period, right? And so we have to be, I think that obviously the government has a big part to play in the initiatives that are coming through. But I know it's a bigger conversation for the HCCSSs across the province, really to ensure that, yeah, there should be somebody really in that role in every single region. Even though that's still not enough, but I think it's really important because the regions look so different depending on where you're going, and what demographic you might be serving, say in Waterloo, Wellington, may not look the same, say in Peel or Guelph, right? And so it does prove to be challenging. For example, I have a friend that I used to work with Children's Aid, and she's worried about elder abuse for a grandmother that lives in Toronto. And so I told her, okay, I'm going to see what services I can find for you in Toronto. And so, it makes it very challenging for her having, if she didn't know me, who would she ask, kind of thing, right? And so, yeah, that is something that really is a bigger conversation that I think needs to happen. And I'm sure it's happening, but yeah, it's very slow moving wheel. That's what I want to say.
Yeah, I appreciate that insight. And, that's one of the things that, we've talked about as many of you have been involved in this work for many years, is having that sort of, we're talking about intervention and how difficult it is to navigate. So like everyone kind of knows, we have CMHA pretty much across the province in most places. OPP is across the province. Ottawa is different because it's just one jurisdiction, but home and community care is across the province. So that's sort of that integration. So Kim, maybe you could speak to your work at CMHA, because I know their Peel region has a similar kind of program. So maybe you could just speak to the work that you're doing at CMHA. Is there other programs besides yours, or how you sustain the program that you're in within CMHA?
Yeah, so I can't speak to how CMHA Peel does their structures their seniors at risk program, but it is called the same thing. They also have one clinician as well. So we're structured where I receive all the referrals, do the consults, and triage the referrals that come in, because everybody's sort of level and threshold of risk and urgency is different. So sometimes it's just about dialoguing, even with agencies, just about, okay, like, have you thought about this? Let's look at this. Just to create that dialogue can be helpful as well too. But we do a lot of partnerships. I think that's the key piece in the work that we do is the collaboration. We connect back into EAPO for that, education, awareness. We connect into, in Waterloo region, we have the Elder Abuse Prevention Council. So we connect back into there, and it's about education, awareness. We really want to build the capacity of our community to recognize and identify vulnerable seniors and where to sort of go, or even start that conversation with our older adults in our community. So we really do believe in education and awareness as a key piece there. In regards to funding, we do have we do fall under CMHA and the senior services. So we do have that piece there. But I think what we're seeing as an increase in our community is just the complexity between the intersection of, our older adults who are aging with health conditions, possibly dementia, and then possibly mental health. And then you have the vulnerability and the social aspects of it. So there's a lot of things that are always happening at the same time, which I think adds to the complexity of our work and sometimes the challenges in getting the right services at the right time to people and connecting them that way.
Yeah, that's a good point. I think that it is, that intersectionality piece is, I think we talked about before we started, is so important, and it's a growing issue that we need to, address. And also the wait times for people to sometimes get that can sometimes, hinder that response piece. And it's, obviously that's a system issue that we need to, as a province, try to address. But I think that you're real good point there around that we need to work collaboratively with each other, and, paying attention to the different issues that some individuals may be experiencing, or challenges that they're having to, work with our different partners is key. Just trying to go over to Katherine, is that similar in terms of your role or mandate or rollout? I know that there is mental health officers in different police services, but is your role unique to just your region, or is it similar across other jurisdictions? So our delegates that are joining us today can maybe tap into people within their area that if they have a concern for an older person, how they would connect with OPP or regional police.
Yeah, I know every mobile response program operates a little bit differently. I feel like it needs to be adapted according to the region in which people are working in. So demographically, like I said, it doesn't make sense for us to, be secondary response based on the number of calls that we actually get. We just be hanging out in the office all the time. So they tend to implement us in lots of other ways in our community. But I would say that, so just to go back to your initial question or whatever, our funding is actually base funding from the LIN, and we've been in operation for 8 years now. And so we are funded for 2 full-time, 1 part-time for Norfolk. We're also funded for 2 full-time, 1 part-time for Studeman, and we are in the process of getting this program up and running in Studeman, and it will operate in much the same way that Norfolk is as well. So I know some other programs are on a contract basis, and they're operating, I believe they receive their funding through proceeds of crime. So they kind of have to go on a contract year to year and just see what happens. But we've been very fortunate right from the get-go when we started 8 years ago that our funding has been permanent. So we're lucky that way. Typically, if somebody has a concern for a family member, or sometimes we'll get a neighbor that has a concern for someone or a friend, what they'll often do is they'll phone the police and just say, hey, I'm worried about this person. Can you go out and check on them? Or I'm worried that somebody's been being scammed, or I'm concerned that a family member is taking advantage of someone. Usually someone from the community will place that call to police because they don't know who else to call. So that's often where I get brought into it. If I'm there, I'll actually hear the call for service come in, and I'll either ask to attend, or the officer will just take me along with them. So yeah, and as we educate our community more and more about this program, I will say to people, when you call the police, you can specifically ask for the mental health worker to attend. And we can make those connections to services. We do assessments in the home, like we do some of those cognitive tests. I'm assessing for delirium. I'm assessing for family members, maybe siblings that are fighting over who's going to be the POA. We're looking at all kinds of different things. And then I will connect people to the services that they need in our community, whether that's our senior support services, our Alzheimer's Society. We have a senior geriatric team through Community Addiction and Mental Health Services. I work very, very closely with them. They will go into the home and they will also do more of that long-term case management and get people connected to the services that they need. So we do lots of partnering that way. But yes, if it's just a question, right? So if anybody has any concerns or they are worried about someone in our community, if they call the police directly, we can make that partnership happen. And then sometimes when we have crimes that happen, they're benchmark crimes. So they end up going up to our crime unit when there's been scams, and our crime unit has utilized us sometimes too. So sometimes we'll go out with the crime team when they're trying to talk to seniors about what's happened and that type of thing. So
Great. I'm just going to go on, take us to a little bit different stream on risk management. So a minute of you just talked about that, Katherine, and I know Samantha, you've talked about looking at assessing risk. So for each of you, how do you, what is your role in terms of assessing risk? Is there, Brad, at intake, is there questions that you ask specifically around risk assessment, and what do you determine? Like, if it's an elevated risk, do you use other community hub programs that look at high risk cases, or do you do it internally, or does that elevate the risk in terms of priority for response? So is there specific tools, and how do you manage that risk assessment piece in your communities? Maybe I'll start with Brad.
Yeah, this again, I'm not the intake worker, but I mean, I'll give you the best answer I can, knowing that we have a very specific intake form that we use, which has very specific questions. So at intake, when a call comes in, all aspects of the situation are discussed as far as the client wants to discuss them, obviously, right? But there are a few key things that we definitely include in our, when we're assessing for risk. And is it safe to leave a message? Is there an alternate way to communicate with somebody? Do they happen to live with the abuser? We will discuss a safety plan with them as well during the call to ensure that, they understand, because as some of the other providers on the call, we're not 24 hours a day, 7 days a week. So if we get a call on a Friday and, we want to be able to discuss a safety plan should something happen on the weekend. So that's one of the important elements that we do. And obviously making it clear, that 911's an option for people as well. We can also meet somebody in a designated spot, which is not their place of residence. They could come into our office, or we can meet them in the community somewhere that's safer. And we always involve our clients in the decision-making process. That's another part that we feel is important. The more we can engage and involve them, that's sort of a risk assessment area as well. And are there other supports coming into the home? I think that's an important element, because it's more eyes on the situation. And of course, there's there's the consent to speak to other organizations or support services that may be going into the home. So those things are all questions that we do ask in intake. Now, we don't necessarily get all of this information in the initial intake, because it sometimes can take 2 hours to get through everything, because individuals who are being abused or in a vulnerable situation, talk a lot about what's happening to them, and we don't necessarily get through everything in the initial intake, but we certainly focus on making sure that we have the answers to some of these questions.
Great, thank you. Smith, I saw your sort of head nodding in terms of, your role. I would assume, being that vulnerable lead, that you do that risk management piece in your capacity.
Yeah, so we definitely do, like the clinician does do the risk assessment piece. Again, looking at a person holistically, looking at the environment, looking at, their mental health, all those pieces that are impacting where they are now and what's happening right now. Our referral system is anybody can call in. We have a crisis line here 24/7 that is there 24 hours a day, 7 days a week. And we have our referral form actually go through into here 24/7 for that fact that referral forms, referral phone calls come in at all hours of the day. So they're there to pick up those pieces, when we're not there the other times. But they can, if they get a referral form, they always review the referral form. That has as much information as possible. We encourage people to send as much information, especially if it's an agency or if it's a hospital, include it. And then they take a look at it just to, see if anything stands out that's really high risk. Then they will reach out to the referral source or reach out to the alternate contacts or the client themselves. So we have that piece there. But otherwise, like, we get phone calls from anyone in the community. We've had random phone calls, my neighbor, I'm concerned about them. They might be having some difficulties with, A, B, and C, and then not sure where to go from there. So, so then that's what we do. We get a lot of phone calls everywhere.
Great, thanks. And Joanne, I'm assuming that your capacity, that there's obviously some risk management procedures there, and then the home care workers that are going to the homes would obviously do some of those questioning as well. Is there anything else you may want to add that's a little bit different than what's been shared?
Well, Brad made a really good point. Like, so when there's services in the homes, we have more eyes on in the home, right? And so not only when you have PSWs and you have nurses and you have maybe even less formal care providers in the home, or if they're going to day programs, then you have a lot of eyes on that person. When it comes to risk, when they go into the hospitals, even family doctor's offices, a lot of the times we're hearing about the interactions between older adults and their adult children, right? A lot of the times they're just like, I wasn't really comfortable with the way they interacted with this person, right? And so we ask a lot of questions surrounding that, and we want to know what the background is. And one thing when it comes to risk management is that risk is relative, and that's where that's where consent and capacity and decision making really comes into play, because as service providers, we might be looking at it one way, the police might be looking at it another way, the family might be looking at it another way, and then the client's just like, yeah, I don't see it, right? And so it's really looking at those different pieces, because yes, Sam said it, we really have to look at each client holistically, and then trying to understand the family dynamic that brings this person to where they are now.
Great. Yeah, thank you. I think that's so important, because like you say, the perspective of what risk looks like for each individual is so different. And as providers, we may see it as like, oh my goodness, the person needs to get help right away, and they say, oh, it's fine, it's always been like this, right? So they don't see that escalation. One of the things that everyone's been talking, the importance of community collaboration and working together with partnerships. How do you all address the issue of sharing client information across different community partners that you're working with? I know that sometimes is a barrier when we talk about consultation teams, and I don't know if you sit on those or host those as well, but that sometimes can limit people from reaching out, getting that consent, or that just sharing that client information. How do you address that? I'm going to start with actually, I'm going to go back to Samantha, just because you just talked about that.
So when it comes to consent, obviously, with our referral form, we always ask that, like, there's a little tick box that asks that if there is consent by the client to know that they're being referred to our program. Obviously, sometimes they can't get the consent, but then we sort of tackle it we come at it from a different angle, that, we're there to provide support or help people make those connections. We do have different meeting tables that we do talk about clients where people can bring, agencies can bring their concerns to. We have a seniors at risk consultation meeting where people can discuss cases, obviously in a confidential manner, anonymously. Sometimes it's just that it's opening up that dialogue to assist each other about, have you thought about this? Because it helps people just to step back a little bit. Sometimes when we're so involved, you can't see the bigger picture. So we help people just to let's step back and take a look at this case and go from there. I hope I answered your question.
Is that internal, Samantha? Is that like that consultation with your team about sharing, or is that with external partners, that consultation?
That's with external partners. We
Okay.
also have our own internal meeting where we have like our team, like our seniors meeting team, that we come together at our huddle and we talk about cases, referrals that have come in.
Okay. And Katherine, how does that work with your role with mental health and OPP in terms of sharing that information with, getting the consent, or if the person doesn't have maybe the capacity to make that informed decision? How do you deal with those kind of situations? Because you did mention about responding to situations where an older person may not have the ability to make informed decisions.
Mm-hmm. So because my partner and I, we would be there at the call together, we're both getting the same information at the same time. So the need for consent and for, I guess being concerned about breaching confidentiality. I mean, we're at the same call together. So all the information is coming to both of us at the same time. Sometimes what happens if there are concerns around abuse, sometimes people are afraid to talk to police about a family member because they fear the repercussions of that. One of the things that I do, and our officers are aware of it, is that if I can talk to the individual on their own, they can disclose that to me. And I don't have the same obligation as an officer to, I do to protect the person and to get them. They may not want charges laid is my point, and the officer will have an obligation right away to lay a charge. I can implement some other safety supports and some other, services that would support the elderly person without there having to be criminal charges per se. It kind of gets into a sticky situation. It happens with domestic assault sometimes too, right? Like, people don't want to necessarily tell the police because they don't want charges, but they might disclose it to me, and then I will help them get connected to safety and supports and that kind of thing. So it's hard sometimes. You really have to do this weird little dance, and determine the risk, right? And do I have an obligation to report this to the police myself, because it is a vulnerable person? But I try and do that in a supportive role with the person that I'm with, and really advocate for them and do that. And then usually when we're responding to a call, there is some sort of concern or imminent risk. So in terms of circle of care, usually I will say, would you be okay with me letting your family doctor know that I was here today? And can I share the information with your family doctor around, what we talked about today? And almost always people say yes. Or, do you have a family member that you would be okay with me talking to, because I'm worried about you. And usually I will get a yes out of that. So a lot of my consent, because it's in the moment, is verbal, but then I'm usually not involved all that much longer. So I don't really need the continued consent.
Okay, great. What I was going to just maybe shift into the education piece, or just one more thing. In terms of like referrals, there's always that question, what is the most common referral that you make? Is it to mental health services? Is it to the public guardian trustee's office? Like, what are you seeing as trends right now with those who are reaching out for support and intervention? And what are the key issues that you're dealing with, and who are those primary areas or services that you're making those referrals to? Maybe I'll start with Brad.
Yeah, for our program, there's a lot of financial abuse that comes, and the complexity involved in these situations and cases often means that we need to refer or make the connection with multiple other organizations. One of our challenges, though, is the fact that we're not in a position to be able to support people from a legal perspective in any way. And we, other than we can refer them to a place like West End Legal Services, which can help support people with some pro bono or free services. But typically for most people, their situation is beyond that, where they need an actual lawyer to sort through the family dynamics that are associated with the abuse that's taking place, or the abuse at the hands of somebody that a family member that they're living with. And there's a hefty price tag for that. So that is one of our leading sort of referral sources is to a lawyer. Also housing agencies, where we find a lot of situations are because they're living with the abuser, which means the solution in front of you is relocation, move somewhere, but that's not as easy as it sounds either, just because of people's financial capacities, their mental health capacity at the time, and their reliance on the actual abuser. So that's we do a lot of that work with housing as well. And mediation is another source that we find can sort of alleviate maybe going the route of a lawyer, or if you can mediate this financial stuff that's happening within the family dynamics, that it's actually far more cost effective than going to a lawyer. But sometimes it's difficult to get people to actually see that and understand that. And primary care outreach here in Ottawa is also another major source, because if we can get a presence in the home again, as I go back to more eyes on the person, which is always beneficial. So those are some of them, but believe me, we have referred to a lot of different organizations.
Joanne, what are you seeing as trends, especially within home and community care? We have a few more minutes left just in talking about, what are your challenges? Like, what are you seeing as trends, and how, how do we shift to maybe address those in the future?
So just like Brad, financial, it's a lot of financial. Some of it is warranted and some of it's not, depending on what the situation is. And sometimes really it just comes down to us really helping to educate the individual or the family members about setting boundaries around how and who has access to their accounts. It's not always the big stuff, right? And another big one is romance scams and that grandparent scams. We're getting that, like the romance scams, people are lonely, they're looking for companionship, and they'll talk to anybody, and then it turns into this manipulative psychological relationship that we can't get in front of, because they're talking to this person every day and we're not talking to them every day, and we're also not giving them the companionship that they need. So those are the two big ones.
Are you seeing misuse of power of attorney in that first part of that financial abuse you were talking about?
Sometimes it's power of attorney, sometimes it's just an adult child who's just living off of elderly mom. Yeah,
unfortunately. And Samantha?
For referrals, because our program is so broad, we cover so much stuff. Referrals can go to anywhere, kind of like what Brad was saying, right? Like it can be anywhere. We're not legal as well too, but we've had to tell people, you may need to contact legal aid and get some support that way. Home and community care is probably a big piece, a big area where we refer to, especially if someone has never connected in to any services and are just, hanging on at home, trying to manage. And we try to get home and community care in so that there are more eyes in, kind of like what Brad was saying, just that more support. We want to, keep and maintain people's goals. And oftentimes that goal is to remain at home as long as possible. So home and community care, doing the in-home Support is important. We also have primary care at home in our area in Guelph, so we can try to connect, primary care nursing or social work in. If somebody's homebound and they can't get to their doctor's office, we have community paramedics that come in as well too, that we can make that referral. It's really about trying to wrap different supports around that person.
Great. And Katherine, and then we're going to wrap it up after maybe Katherine just talking about, what do you see as a current trend or challenges that you're seeing? And then how do you see the sort of the future and in your role and your capacity in terms of supporting seniors?
So kind of the trend we're seeing are a lot of cognitive impairment, a lot of people wandering away. We have a lot of missing persons that come up. I guess the loneliness and the isolation is a big thing. I mean, that makes people far more vulnerable. So I try to make appropriate connections to our senior support services, because they have day program activities that people can go to. They have volunteers that will call on a daily basis to check in and do some of that friendly visiting. One of the big ones that I also refer to is our senior support services, like our geriatric services team with community addiction and mental health, because they have the ability to go in they can go bi-weekly or twice a week if they want to. Like, it just depends on the needs of the person, and they too are in there, and they will make those connection to services, whether it's home or community care coming in or a PSW, or they do all those other connection to services. My one go-to is our geriatric services team, because then if I can get them in the home, then I know that all those other connections are going to happen. Another big one is our Alzheimer's Society. We work very, very closely with them. We have a really good partnership with them in our behavioral supports as well. So yeah, I feel like we've got, and our paramed too, they're really great. Sometimes we show up at calls with EMS, and right away they'll say, okay, what do you think? We'll do a quick little consultation, like, yeah, good candidate for a paramed. And then they get that service rolling too. So as everyone has said, that eyes on in the home, the more people that are there that can observe and get a sense of what's going on, that seems to be best practice.
Great. Well, I want to thank everybody here for taking the time to share your programs with the delegates here today. I know that the really important key tips here is, getting to know what services are available, whether they're in your jurisdiction, if they're coming from there or elsewhere, tapping into, let's say, 2-on-1, a database to find out where people can at least start if they don't have that. And I think the other takeaway is to advocate for the services within having that consistency, as Joanne was talking about, and Samantha, everybody, in terms of the need for that, and so people know that they're where to go and when they do need that support. So it's not like that puzzle they're trying to put the pieces together, that sometimes it takes so long to figure out that navigation process. So thank you all for your insights today. We will be posting some of the links to your programs on our website after with our conference proceedings. So thank you again. And if anybody wants to network with our speakers, I know that they are on FeedLoop for the conference today, or many of them are. So if they are alive and they're joining us, you can also have conversations with them through the speakers panel as well. So thank you again. Enjoy the rest of the conference, and we will see everybody after the lunch break at 1:15. Thank you.